Great. Okay. Well, welcome to today's webinar. The title of it is How Quality Improvers Can Incorporate Behavioural Insights to Change Behaviour. I'm Eric Barrett and am hosting today's session. I'm Health and Wellbeing Lead at Kenton Medway NHS and Social Care Partnership Trust, and I'm a founding member of the Health Foundation's Q community and convener of the Behavioural Insights Special Interest Group. Special thanks go out to Matthew for instigating today's session, and to Anita, Joriam and Hassan for helping to bring it together. There will be an opportunity for a Q&A after the presentation, but without further ado, I am going to hand over to Professor Ivo Vlaev, who is Professor of Behavioural Science at Warwick Business School at the University of Warwick, who will be presenting on how we can gain more understanding of practical behavioural insights and useful ways to consider these in our quality improvement work. Over to you, Ivo.
Thank you, Eric. And I'm really delighted to be here. And just to say that my background is in psychology. I'm a psychologist and actually a neuroscientist who helps people make better decisions and also change their behaviors. So I kind of manipulate people for a living, but only for their own benefit and the benefit of society as a whole, and especially the benefit of the healthcare system. And the theme is about incorporating behavioral insights to change human behaviors. I just want to mention that my work brought me to this presentation over the last 10 years from the desktop, from the lab space. I spent quite a lot of time in my early career trying to understand why the bottle of human rationality is half empty, why sometimes we make decisions that we later regret, and why sometimes we make decisions that we never act on, like the New Year resolutions that we always commit to, but we never implement in practice. And a lot of the quality improvement is about implementing evidence-based medicine, and many of the healthcare professionals fail to do so, which is the key question that we're trying to understand using behavioral insights, being funded by the health foundations. So if you have further questions, want to know more about the work I do with the different behavioral units in government, such as the behavioral unit of the Department of Health and Social Care, what used to be the behavioral unit of Public Health England, you can find more information on my webpage. But I have been working with pretty much every department at Whitehall for the last 10 years. From a blue sky scientist living in an ivory tower down to a real messy world of policy making, applying behavioral science in policy. So, well, as you can imagine, many of the biggest policy challenges in health we are now facing, smoking, obesity, and healthcare associated infections, also relate to the choices people make: to smoke, to drink, to eat poorly, and not to take enough exercise, to take drugs even. Significant financial and societal costs of unhealthy behaviors like smoking, alcohol, and misuse and obesity are driven by. And as you can see, why do we need to talk about behavioral change? It's a no-brainer. 72% of the deaths are attributed to non-communicable diseases, largely attributed to modifiable behaviors, such as physical activity, diet, and smoking. As you can see, cardiovascular disease, chronic respiratory disease, or liver disease. Just to kind of introduce the topic of behavioral change, which was created, the need for behavioral change in public health, but now we realize we need to apply behavioral insights in quality of care to improve the quality of care. And obviously, many of us and many other governments and practitioners realize the need for behavioral science. This is why we have behavioral units growing like mushrooms across the world in different organizations. This is a map by OECD from 2018, showing the behavioral units in governments. There used to be 230. Now there is a new map produced on the website of OECD. There are more than 400 units out there in various organizations. So it's really a popular field, and hopefully you learn some of these insights and hopefully you apply them to improve the quality of care. Well, let's start with a simple question. What is behavior? It's not obvious, really, what is behavior. If you think it is, it's not. So there was a multidisciplinary consensus in 2014, which arrived at a very simple definition. Behavior is anything a person does in response to internal or external events. Actions could be overt, motor or verbal, and directly measurable, visible, or covert, not viewable, and indirectly measurable, involving voluntary muscle. So essentially, behaviors are physical events that occur in the body and are controlled by the brain, as simple as it is. You think it might be obvious what is a behavior now after definition. Let's see if you understood it correctly. Just a quick quiz. I'm going to point to a specific event or action or something else, and you have to think on the top of your head, is that a behavior or not? Walking in the park, is that a behavior or not? This is a behavior. It's action produced by the brain voluntarily. What about having the confidence to ride a bike? Is this a behavior? We always need to start to think about what is a behavior in order to understand how we might change this behavior. Well, confidence is not a behavior. Confidence is something that determines and drives behavior. We need to improve the confidence of the person or a doctor or a nurse in order to change their actions. Improve as a result of applying behavioral insights. Increase the confidence. Taking a statin tablet, is this a behavior or not? Yes, it is. It's a physical action in the body, by the body, controlled by the brain. What about losing weight? Well, this is not a behavior, it's a consequences from changing somebody's behavior. You change your diet, you start exercising, and you lose weight. What about speaking with a louder voice? Yes, obviously, I'm sure you guessed it right. This is a behavior. Intending to eat 3 pieces of fruit a day, is this a behavior or not? No, it isn't. You change somebody's intentions using behavioral insights, designing interventions. As a result of changing their intentions, they change their behaviors and start eating 3 pieces of fruit a day. What about smiling when talked to? Yes, obviously this is a behavior. And reducing cholesterol? I'm sure you can see it coming now and guessing it right. No, it isn't. You change somebody's behavior as a result of which they reduce the cholesterol. So when we design behavioral change interventions, the first task is to actually figure out what are the behaviors necessary to achieve a desired outcome. A desired outcome is determined by several different behaviors. For example, obesity is a desired outcome, a multitude of behaviors driving obesity, and they interact in a complex way within a system. Changing diet, making people exercise, changing the environment, the availability of fast food outlets outside schools, or availability of healthy food in the canteen or the workplace. The different factors, behavioral or not, that determine the outcome of interest, and we need to think systemically. So even when we talk about improving quality of care in the health system, the different so-called engagement zones or domains within the complex system in healthcare, where we can actually target our behavioral change interventions, such as public health, preventive health, and lifestyle behaviors that I mentioned. But also self-care of patients, how they interact with the pharmacy, and do they seek help when they interact with the pharmacists who can actually provide diagnosis or treatment and prescriptions, or clinical decision-making of clinicians, providing diagnosis, adhering to evidence-based medicine, implementing evidence-based practice, and long-term care, providing patient support and adherence. So we need to improve adherence to medication and treatments as a result of behavioral change interventions. So as you can see, even within a complex care system, we can zoom in on specific domains where we need to create interventions to improve the quality of care, like public health, pharmacy, clinical decision making. And we did so. We have actually a funded project. I want to use the opportunity to mention here, funded by the Health Foundation, which actually enabled us to review all the evidence of nudge interventions, behavioral change interventions, to optimize medication prescribing, nudging prescribers, healthcare professionals to optimize the prescribing by essentially prescribing medications which are cheaper but as effective as the most expensive medications, and thus saving resources for the health provider. And you can find the systematic review of all these effective interventions online. I'm happy to send you the article. So when we design interventions, we need to be very specific. What behavior we're going to target? And we need to be specific in terms of defining this behavior, in terms of who needs to do what, with whom, how often, when, where do they need to do it, In what context do we need to do it? Being more specific about which behaviors we're trying to change allows us to be more focused when it comes to understanding these behaviors, essentially by contextualizing the behaviors in terms of who needs to do what, when, where, how often, with whom. This is no brainer. You have to be specific because otherwise we might miss opportunities to intervene and change these behaviors. So the first task is behavioral specifications. Let's start with something that we're going to talk in more detail today, hand hygiene. We want to change behavior, essentially target behavior being cleaning hands using alcohol gel. Well, what do we need to do? We need to make all hospital staff to change their behavior. So who needs to change the behavior? All hospital staff. What do we need to do differently to achieve the desired behavior? Clean hands using alcohol gel. When do they need to do it? During each shift. Where do they need to do it? On hospital premises. How often do they need to do it? Well, now it becomes interesting to see the contextualization and the definition becoming very specific, which allows us to understand this behavior. At the start of each shift, after using the toilet, before physical contact with the patient, after physical contact with the patient, after contact with potentially contaminated materials, with whom do you need to do it? Alone. We need to start with the behavioral definitions, and then things become really clear and obvious. So what is actually behavioral change intervention? Now, we understood what the behavior is. So what is the intervention to change this behavior? Well, essentially, in summary, it's an action or set of activities to get individuals to behave differently from how they would act without such an intervention. Your intervention can change how people behave, how often they perform the behavior, how long they act for, over what time period is one-off behavior, when, for example, you turn up for your cancer screening, or repeated behavior, such as eating healthy diets. So when it comes to behavioral change interventions, traditionally, we actually used to think in a very simple way about what we need to do. Essentially persuade people, provide information and incentives to change their minds, beliefs, and attitudes, as a result of which they change their intentions and change their behaviors. But what turns out to be the case is only a minority of human action is what we know from psychology, determined by this reflective, slow, rational way of thinking. And Mr. Spock, Vulcan, his omnipotent, very rational creature in our brain, only explains 20% of human action. Turns out to be the case because there are two different ways of thinking, two different systems in the brain, which work in an interactive but complex division of labor when producing the behavior. It turns out to be the case that the majority of human action is actually driven by our very fast, unconscious mental process, automatic associations, involuntary control over these actions, and effortless decision-making. So when you find yourself in a specific information environment, if you see this information as familiar and you recognize it, automatically triggers this fast subconscious decision-making, a bit more like this hapless creature, Homer Simpson. The majority of human behavior just comes about, it's not reflectively thought about, driven by our very human, emotional, and fallible brain. And only rarely when the stakes are high and the situation is novel, we engage our rational process. And these two ways of thinking and reasoning and deciding and acting tend to override and compete with each other and also interact in a very complex way. So we need to think very carefully when we actually discuss possibilities to influence people. Don't focus only on the low-hanging fruit, which includes rational persuasion. And let me illustrate how these automatic ways work, subconsciously outside of our control. Let me ask you the question, which of these squares, A or B, is lightest? Have a think about it. Look at the squares, which is lightest? I bet you're telling me it's B. Well, in fact, they're both the same color. If I remove the context, you see their real color. I'm telling you the same color, but you cannot change your perceptions. The power of subconscious automatic processing in the brain. The reason you see them as different is because obviously your brain recognizes the pattern of dark and light squares, and it assumes that because B is surrounded by dark squares, B must be light. But also the brain kind of sees that the B is dark, a bit darker. The brain rationalizes this slightly darker color of B by looking at the green cone and the shadow thrown over B, and it, in this way explains away why B is darker. There is a shadow. And it makes the inference, yeah, B is still lighter than A, is a white square, given the pattern I see of dark and light squares. But the reason I see it is darker is because of the shadow. And all this processing is going very fast in your brain as you're seeing the picture. It feels like it's immediately popping up in your head, the perception. But in fact, the subconscious, automatic, outside of your awareness and control processing is very fast and very sophisticated, and you don't have any control. Even if I'm telling you they're the same, you still see them as different. Another good example of automatic processing is the phenomenon known as loss aversion. Essentially, we hate small losses, and a small loss is actually engaging us emotionally much stronger than a gain of the same amount. If I go to the bathroom and lose 10 pounds, I feel miserable and my well-being is decreased. If I find my 10 pounds on the way out of the bathroom, I feel happy because I found it, but overall my happiness is decreased because the pain from losing 10 pounds is stronger than the pleasure finding 10 pounds. So if you focus attention on the possible loss, it affects your behavior. In this case, it's a simple intervention trying to measure the effect of providing the side effects from a new treatment in terms of the possible losses or possible gains, or you can see how it works in this case, which affected the decision-making of a rational creature, the doctor. Physicians asked to read about new asthma medicine, and the data show that this new drug has side effects. So some clinicians are presented with information about the side effects in terms of 95% of the patients were not hospitalized with exacerbation during the first month of therapy. And another bunch of clinicians are presented with the same information, but framed in terms of possible losses, which read 5% of the patients were hospitalized with side effects. As you can see, the same information. If 95% are not hospitalized, it means 5% are hospitalized. If 5% hospitalized, means that 95% are not hospitalized. This framing, this focus on the gains or the losses should not affect the clinical decisions. But when they are asked on a scale from 1 to 10, low to high, what is your enthusiasm for adopting your medicine? In the positive frame, 95% were not hospitalized, 6.5. In the negative loss frame, in terms of 5% of patients being hospitalized, the enthusiasm is lower. So even doctors prescribing medicine are affected by this process. So another quick subconscious bias, I want you to go with me and experience it yourself, is known as priming bias or availability bias. So have a think about two types of words. Words with the letter K in the first position and words with the letter K in the third position. Which type of word is more common in English? Have a think about for about 30 seconds, write them down or on the top of your head and make a decision. I'm giving you 30 seconds. Here we go. End of the game. Well, as you can imagine, I'm sure many of you thought that words with the letter K in the first position are more common, mostly because they're more likely to pop in your head, or they're more accessible in memory when you start thinking about words starting with the letter K, such as knowledge. In fact, words with the letter K in the third position are much more common, such as like, take, bake, acknowledge, ink, and so on and so forth, but they're not accessible. This is a specific bias. What is accessible immediately in our memory affects our decision, which is going to see how it works in practice when we're actually trying to change people's behavior using a specific automatic phenomenon, automatic process in our brain, which controls behaviors. And now we arrive at the idea of nudging. Nudge. There was a thin but conceptually quite thick book published in 2008, which changed how we think about behavioral science in practice. Nudge, Improving Decisions About Health, Wealth, and Happiness by Richard Taylor, who is now Nobel Prize winner, because of this book and applying this idea of nudging in public policy, and Cass Sunstein, who is an omnipotent polymath academic working at Harvard. And they had a very simple idea. Essentially, turning the whole debate about what can we do about human irrationality upside down. Until then, the answer to this question was people should know better, make them in control of their behaviors, tell them off that they're stupid, provide them with persuasion and arguments, and engaging their rational minds to change their behaviors, which doesn't work if only about, well, a fifth of human actions are controlled by the brain in a rational way. They said something simple. Let's go with the grain of human nature. If people are automatic and subconscious in the way they make their decisions, triggered by the environment majority of the times, let them be. Let's switch on these behaviors, these automatic tendencies, trigger these so-called biases, and change their behaviors in automatic and subconscious ways. But the benefit should be for the individual from this behavior and the society as a whole. The idea of nudging was born. Nudge essentially is any aspect of the environment that changes people's behavior in a predictable way without forbidding any options or significantly changing the economic incentives. And this is the so-called oxymoron libertarian paternalism, essentially that we should change behavior. It's legitimate to change private and public behaviors in order to make lives better for longer, by also respecting freedom of choice, not taking liberties away. Let me give you a simple example of nudging from the book that really brought the imagination of policymakers to the table and of policymaking, and they really start implementing these ideas in practice. Can you recognize this object here? Maybe not. This is not the famous art installation by Duchamp in Brussels from the 1930s, the fountain. This is a pissoir at Schiphol Airport, where the first nudge was born. And the challenge was very simple at the time. Men have lousy aim. There is a spillage outside. If you have boys at home, probably you know that better than me. I have a son, he doesn't even switch on the lights when he goes to the bathroom. So the solution to this challenge, behavioral challenge, was to persuade men attending the public toilet to aim better with some labels above the pissoir, persuading and informing the visitors, please aim better, because it's an emotional cost, stinks, and also financial cost. We need to pay somebody to clean, no affecting behavior. A simple nudge change their behavior in automatic ways without them being aware of this influence. A fly etched at the bottom of the pissoir reduced spillage by 80%. Shocking. So, as you can imagine, this automatic, costly, effective behavioral change intervention. It doesn't cost anything to paint a fly at the bottom of the urinal, relying on these automatic responses. Men used to be hunter-gatherers for hundreds of thousands of years. So each time they have a tool in their hands and a target to aim at, they automatically aim at the target and feel rewarding signal in the brain, dopamine rush when they hit the target. Let's rely on this process. Another example from the book. Can you recognize this place? No, this is Lakeshore Drive in Chicago. The challenge was, there's a sharp turnaround on the right side of this picture, as you can see here, and cars and drivers are wiping out quite a few car accidents. What the government wanted to do at the time was persuade drivers to slow down by providing a lot of information, billboards, radio campaigns costing a lot of money, not affecting drivers' behavior. A simple nudge, simple stimulus in the environment that triggers automatic behaviors solve the problem. Can you see it? Lines on the motorway was the solution. As you can see the lines, maybe carefully, they're getting closer and closer to each other as we're approaching the right sharp turnaround. And even though you're driving with the same speed, the subjective feeling is that you're speeding up. The lines pass faster and faster in front of your eyes, and you're feeling that you're speeding up. And what's the knee-jerk response? Hit the pedal to slow down, which is exactly what the drivers did, which reduced crashes by 36% in the first 6 months of the trial. And here's the Nobel Prize winner explaining this idea.
So another domain in which we see nudges is in safety. There's a beautiful road here in Chicago called Lakeshore Drive, and there's a dangerous S-curve right downtown where people are constantly wiping out. So what the city's done is painted lines on the road, and as you drive up to the most dangerous part of the curve, the lines are closer together, which gives you the illusion that you're speeding up. So you tap the brake and slow down, which is exactly what you want to do. You've been nudged.
Here we go. And the final example, can you recognize this object? I bet you can't. This is the power of cute. And the video speaks for itself. how cute images can melt the hearts of criminals and reduce antisocial behaviors in London.
As the London riots of 2011 took hold, people in Greenwich burnt down the pub they drank in and looted the shops where they bought their food. But as the disturbances died down elsewhere, antisocial behaviour in the area continued. Greenwich Council needed to find a way to stop the problem minority from destroying their own community. We believed that the shop shutters that were ripped from their runners were part of the problem. Could we turn the shutters into part of the solution? We wanted to conduct a social experiment. In 2009, a team of scientists from Pennsylvania found proof that the large head, round face, and big eyes so beloved of Disney actually motivates caring behaviour in adults. They proved that cute matters to the brain.
If I was in local government, I know it would be a lot easier to say I'm getting more police out there than to say I'm painting a few shutters. And I think we need to work to build confidence that these kind of interventions have their role, that they work and they have their role, and get them taken as seriously as hard interventions, which are expensive and in the past have proven not to work.
Could the power of cute minimise antisocial behaviour in Greenwich? After a campaign to recruit babies from the local area and a long night painting, we turned the unused and inhuman metal sheets into giant portraits of Greenwich babies. As the shops shut at night, the metal shutters came down to reveal the babies when they were needed most. It had a powerful effect on the community, with an 18% reduction in crime, and locals who say they feel much safer.
If you've got positive images around, it makes you think positively.
They are amazing.
I think there should be more of it. Yeah, I think it's a good idea.
And it didn't take thousands of pounds or hundreds of police. Just a few cans of paint. The people of Greenwich have shown an overwhelming love for the babies, and the shopkeepers have embraced the idea as their own. Before long, other communities all around the world, from Belfast to the Bronx, were talking about it too. What started as an experiment in London is now being rolled out in Northern Ireland this year. This could be the dawn of a new era in crime prevention.
Who would believe that the most vulnerable members in society, the babies, will be the guardians in society? Several implications. One is to not install security systems at your doorsteps, paint baby faces, people won't dare breaking into your houses. So as you can imagine, after the publication of this book and various anecdotes and case studies, there was an explosion of interest in the public space. A lot of popular books were published, and a lot of government reports were published from different Whitehall departments, such as Department of Health, Communications, Environment Protection, Education. The problem with these reports, however, was they're full of anecdotes, interesting story about baby face and pissoirs and whatnot, but they don't provide a framework, a method to study human behavior. You can entertain your guests at dinner table, maybe apply the same idea if you have the same problem, but it's good to have a tool for practitioners who do not need to become psychologists. And the reason for actually summarizing all this knowledge in something practical is because the anatomy of human automatic motivation, of so-called system 1, this automatic subconscious processing in the brain, is really complex. As you can see here, every white square is a different automatic effect on human behavior. And I was commissioned by the government to summarize this knowledge with a couple of my colleagues who set up the very first behavioral insights team in government, the Nudge unit, David Halper and Michael Halsworth. And that's how Mindspace was born. Essentially, it's a framework of the 9 most effective influences on human behavior, the principles of human behavior, which actually cover a quite broad range of effects. As you can see here, every white square is a different effect. So if you group the ways in which the social environment, for example, influences your decisions, such as in-group, out-group effects, false consensus effects, social influence effects, declarative norm effects, injunctive norm effects, you can actually group and categorize those effects under the label norms. We're influenced by what other people do and value. We have a general principle here, and this is what Mindspace is. M is for messenger, I is for incentives, N is for norms, D is for defaults, A is for saliency, P is for priming, A is for effect, T is for commitments, E is for ego. It's a very practical framework which we use to create interventions, and in the slides you can see all the definitions that you need to start applying these behavioral insights in your practice. And we have a checklist as well for practitioners, how they could implement each principle to prompt them to apply it and to look for specific opportunities to apply each insight. Got the messenger right? We are more likely to act on information if the messenger has authority and expertise, either formally or through life experience, and if we can associate with them, if they're like us, somebody like us. If you like the messenger as well, it's very important, and so on. So please look at the slides and the checklist when you're thinking about solving your problem. So nowadays, there's several operating frameworks that are born after MySpace, such as EAST, which is simplification of MySpace, and the behavioral change wheel. We're going to see how we use that in practice. So let me show you something that is really important for the conversation today, because this trial was funded by the Health Foundation in the context of UK, but the original idea was tested in Miami Hospital, where we had a challenge, which was, despite traditional communication of motivational benefits versus risk, the use of hand sanitizer was too low. Clinicians, healthcare professionals are not washing their hands when they're entering intensive care unit. All they need to do is a heat dispenser and rub their hands with alcohol gel. So we decided to use the priming idea, the priming principle for mind space, which is our acts are often influenced by subconscious cues, such as smells, sights, words, sounds, which tap into our memories and make certain memories more active, the way we saw with the priming / availability bias, which letter starting with which word starting with letter K in the first position, or word starting with letter K in the second position, is more frequent in the English language. And your intuition was, I think, or most people's intuition is, that words starting with the letter K in the first position is more frequent because these words are more available in our memories for various reasons, where in fact words with the letter K in the second position are more frequent. So let's see how we apply the priming principle to improve the hand hygiene in this hospital. And you can see the article here, which is published already. Well, we use very simple intervention. We found evidence that smells remind people of something and they act accordingly, such as citrus smell reminds people of hygiene, because citrus, lemon smell specifically, reminds us of hand washing liquid, the one we use to wash our hands in the bathrooms. So in one intervention arm of this specific trial, we release a smell of citrus in the corridor leading towards the intensive care unit. In another intervention arm of this trial in Miami, we actually wanted to remind people subconsciously that somebody is watching them, prime them with the idea of somebody watching them in order to motivate compliance behavior. And well, how to remind people that somebody's watching them? Well, 2 eyes above the dispenser, male eyes or female eyes. So you had 4 conditions in this trial: male eyes, female eyes, olfactory, citrus smell, and nothing. Which one do you think performed best? In the control condition, only 15% wash their hands when they're entering intensive care unit. It has to be 100%. People dying behind these doors, smell triple the rate of hygiene, and nobody was aware. Asking clinicians and nurses, anything unusual? Sorry, leave me alone. I need to see my patients. Frowning, middle-aged men's eyes, double the rate to 3%. Beautiful female eyes still increased it, but not as much as the other priming stimuli. Well, here we go. We have a solution. So we had funding from the Health Foundation to apply the same principle, the same intervention in UK context, specifically at Heartlands Hospital in Birmingham, which is part of the University Hospital Birmingham's trust now. And these are my colleagues, Kelly Schmidtke. She is also actually co-leading the other trial and other research project, which is still kind of ongoing, just finishing now, on optimizing prescribing behavior. You saw one of the articles before that. So me and Kelly and quite a big team of researchers, we try to engineer environments to increase hand hygiene in hospitals by applying the same idea. And we had several questions: whether 2 primes are better than 1, whether the priming effect persists over a longer period, not just a couple of weeks like in Miami. And we had different types of wards, not just intensive care unit. We had the renal, upper GI, hematology, oncology, and admissions. And we had a factorial design to test whether smells or eyes, or both of them, or nothing, affects behavior more or less. And we had a complicated randomization process. So it was very clinically designed randomized controlled trial, to say so. We observed the entrance to the wards, counting whether people entering or exiting, washing their hands, observing the male or female, what's their profession, and we had a table with the hit rate, 1 if they did so, or the person did so, on 0 otherwise. And we found no result, completely nothing. As you can see here, there was a ward effect. People are more likely to wash their hands in one ward versus another, but there was no difference between different conditions. Quite disappointing result. So, well, we said, let's try to see why, to measure why. Maybe we need to, when we miss something, we're barking on the wrong tree. Maybe something else is influencing compliance here with hand hygiene guidelines. Well, we use another framework which enables to diagnose behavior. And that's why I want to present this framework to you. It's known as the theoretical domains framework. It's part of a bigger theory of behavioral change known as the behavioral change wheel, which starts with a COM-B model: capability, motivation, opportunities, influence, behavior, which is broken down into these theoretical domains, essentially all the psychological factors that can actually influence action, summarizing 33 theories of human behavior into this framework: knowledge, behavior regulation, memory, attention, decision-making, skills, goals, intentions, beliefs about consequences, optimism, reinforcement, and then the various behavioral change techniques associated with each domain. So we focus on the theoretical domains framework because it provides a tool to diagnose the behavior in question. How? Using questionnaire, which is already designed for you. The questionnaire is there. So we decided to step back to more clearly understand the barriers and facilitators to hand hygiene at Birmingham Heartlands Hospital. To do this, we used a survey designed by Judith Dyson to measure the barriers and facilitators that may affect hand hygiene as described by the theoretical domains framework. So the survey asked participants to consider essentially their own hand hygiene practices and then circle a number between 1 and 7 that best reflects their opinion at present. So for example, an item stating, I engage in hand hygiene out of respect for my patients, was designed to capture part of participants' professional identity, a specific domain. And then an item stating, I feel complacent about hand hygiene, was designed to capture part of participants' goals. Well, as you can see, in total, we surveyed 97 individual staff. This chart shows the mean responses to each item by the domain they're meant to capture. Items were reverse coded as necessary, so that higher scores indicate greater barriers. So this chart shows that staff do not report memory as a major barrier. And this might help explain why our primes did not have significant benefits. For example, theoretically speaking, we believe that our olfactory smell primes should work through associative memories, reminding people to clean their hands. And if memory is not a barrier, then it is not surprising that this prime did not work. Another finding suggests that social influences are currently a barrier. As you can see, the bar is quite high for social influences. And they're a barrier to hand hygiene at this specific hospital, which might help explain why our visual prime did not work. Theoretically speaking, we believed our visual prime, the human eyes, both dispenser, should activate organizational or social norms that encourage or enforce hand hygiene. But if organizational norms did not already encourage hand hygiene, then it is not surprising that this prime did not work. Rather, results suggest that an intervention designed to change the organizational culture and the environmental context may have been more effective in this specific context and setting, which is why we designed an event known as Nudge-a-thons. That's the third application or tool that is good for you to learn. The first one was Mindspace, all these nudging techniques. The second was the more comprehensive psychological framework, the theoretical domains framework, is part of the behavioral change wheel, which allows you to diagnose barriers and the questionnaires you can use to do so. And the third one is essentially a design workshop, a hackathon, and call it a nudge-a-thon, that brings stakeholders together to design intervention with a goal in mind, with an aim in mind. And we published the outcome from this hackathon or workshop, this design workshop, in an article which explains our solutions after we observe what are the real barriers in this specific setting. So you can read the article. I'm going to send you the article as well. Co-designing theoretically informed conceptual prototypes for interventions to increase hand hygiene in hospital setting. Well, nudgetons are very interesting tools. So we have a core design team, essentially 2 quality improvement experts, 2 behavioral scientists. Then we had a judging panel, stakeholders who commissioned the study from the Health Foundation, and subject experts, quality improvers, and clinicians from the areas where we want to improve hand hygiene in the hospital, from the clinical domains. And then we had 5 sub-teams, 5 behavioral scientists, 5 designers, 28 nurses, doctors, and practitioners in charge of infection prevention and control in these hospitals. What we do, I spend the morning teaching all these people the tools of behavioral science, the way I'm doing it today. In the afternoon, they break into groups and they solve the problem that we have at the table. And this is the setting at the Shard, which is a skyscraper in London. We have 2 floors there. The business school has a campus there. We use one of the floors. We had an auditorium where I presented the story, the need, the aim and objective of the day, and also the Mindspace framework with a lot of examples. And then we broke down to groups in different locations around the floor to crack the problem using Mindspace framework, already knowing what are the barriers for this specific behavior from the survey using theoretical domains framework. And then at the end of the day, each team presented their solution. And in the remaining 5 minutes, I'm going to show you the solutions briefly. It's really effective way to solve problems using nudgetons, I can tell you that. Because it's not just behavioral experts cracking it like we did with the smells and the ice above the dispenser. It was essentially behavioral scientists who designed the intervention. In this case, we have stakeholders with multiple perspectives, bringing their knowledge and expertise to the table, the understanding of the situation, the context. Now having very specific objective as well, using the behavioral tools or techniques to address a specific barrier, the lack of organizational culture. They present their solutions. We had designers to actually design the solution as they went along during the hours as the team was brainstorming using Mindspace. The designers are crafting the ideas visually. Here we go. The first solution, a gel dispenser, but redesigned gel dispenser, which counts down when used to give an indication of normal daily use. We create a new social norm for this situation. We are meant to have 30 or 300 usages of the gel dispenser. Today, we're still only 30 down, or the 30 left to be done. And we need to do them all at this time today. So it creates expectation, a goal for the team. This is expected from you. Nobody has used dispenser yet. How many are left to 0? 300, 100, depends on the situation. How many times you expect somebody to come in and out of this room or ward. A second solution was, well, shifting from our bed space to a patient's home space, reframing and redesigning the bed space to feel and resemble a patient's home space. There was knowledge shared in the room that healthcare professionals are more likely to wash their hands when they visit the patient's home. You tell me why. Interesting observation. Well, maybe we saw, well, we create new organizational norm by redesigning the space where the clinician and the nurse are seeing the patient, and that will create maybe subconsciously an expectation to wash their hands. A third solution was promoting hand hygiene in handovers and essentially nudging the staff to speak up when they see somebody, their colleagues, not washing their hands. As you can see the badge here on this patient. I'll respond politely when reminded about hand hygiene. So this is the patient and also the doctor and the clinician. They're all wearing this badge. And also we had this sign on the wall, promoting a new sign, a new gesture to use amongst ourselves as clinicians to remind each other about hand hygiene. If we do this gesture, this is a polite way to nudge you to wash your hands, and you and I are wearing this badge that when I do so, you respond politely. You won't be angry at me. And we have this calendar there, John, to be reminded of hand hygiene gestures today, because he didn't do so last day. Well, we also had an interesting solution for the children visiting the pediatric units and their parents. Arakulgo, a toy, gamifying hand hygiene through empowering children and their families and the carers to support quality assurance in staff. Essentially, it's a toy with a card attached to the toy, where the kids or the parent can actually scratch numbers according to how many times they've seen a doctor, to show bare below the elbow, wrapping up their sleeves, or not wrapping up their sleeves, or when they saw, or how many times they saw a clinician washing their hands, or when the clinician didn't wash their hands where they should have washed their hands. Gamifying observation, but also clinicians know that kids and their parents are watching them and playing this game. And finally, what matters to me?
Just a quick logistics nudge. We're approaching the last 10 minutes, yes. Just so you know, so you plan it around.
This is the final slides. These are pediatric admission documents, which are slightly redesigned. What matters to me in my personal care plan when we're admitting children in pediatric hospital? The doctor is writing down the personal care plan for the kid, weight, sleeping pattern, bowel movements. And it feels like the parent has to fill out the form, and essentially underneath there is a tick box where the parent is ticking the box, making salient the reminder, please wash your hands before touching my child. And also the clinician has to tick the box, I wash my hands when I touch your child, or before I touch your child. So here we go. We saw the solutions, and you can find all the evidence in our documents, in our papers, in my slides, and I'll be delighted to hear any questions or opinions. Thank you so much for the attention.
Thank you so much, Ivo. A really insightful presentation in such a condensed short time. So I'm going to hand over straight to Jorian, because we've seen lots of questions coming through the chat box, and perhaps Jorian, to save us time, perhaps you should read them out for us.
Sure. First and foremost, if you folks have any extra questions, there's the reactions button in your Zoom, and I will ask you to use the raise hand function, and then we're going to read in order. I got questions here that I saved throughout the presentation from Lou, Emma, Maya, and Angela. I'm happy to read them out loud, but if you would rather ask your own question, just unmute yourself and go for it. Anybody?
Absolutely. I cannot see all the questions in the chat box because there are quite a few comments here. It's like
Lou just wrote that I can read hers out loud. So
thank you.
First question is, do nudges have a life expectancy? Then are they more successful initially and then taper off, or do they provide a sustainable behavior change?
It's a very good question. I hear this question quite a lot. Well, depends on the situation. We need to run a trial to measure the sustainability of the nudge intervention. In theory, nudges influence mechanisms in your brain which are innate. You come up with this neurobiological makeup, and this is why they work. And they evolve for a reason, to save the brain valuable energy and time, and speed up decision making and improve adaptation in specific situations, broadly speaking. So loss aversion, for example, I mentioned before, we're more averse to losses than we like gains of the same amount. They work across domains and contexts all the time. The same with social norms. Of course, people can counteract to message telling them what their colleagues are doing or approving of. That's fine. We're complicated creatures, but we always respond one way or another to these interventions. So by definition, we do respond all the time, but of course there could be forces in the opposite direction, again, automatic forces or more rational, reflective forces in our brains that drive behaviors one way or another. So we need to take into account all possible barriers to behavior, which could be automatic barriers, automatic psychological influences, or other influences, purely structural influences, infrastructure, availability of space, capabilities and knowledge is another one. We might be motivating people in automatic ways, but if they don't know how and they lack knowledge, nothing is going to happen. So it's important to consider all possible factors when we design intervention. That's why we have these comprehensive checklists like Mindspace and also the other framework that I presented, the theoretical domains framework and the behavioral change wheel as a whole, when we're designing intervention or trying to diagnose the behavioral solution. But overall, we've done several trials with nudges that work in the first situation, in the first instance, and they do continue over time sustainably.
Lovely. Let's go to the next question then, which is by Emma Little. That's said, the examples are great, but it seems that maybe nudges are most appropriate where there is an adjustment that can be made in a physical environment. Given that many organizations now are working in remote/hybrid, are there any examples of nudges that can be used in this context? Thanks.
Or you mean nudges that are not in the situation, that are communicating?
Not physically, but something that could do online or hybrid.
Oh, yes. Well, we use nudging to actually communicate other influences through a digital device, for example. So we work in weight management. For example, one intervention is weight management camp for overweight children, which is a camp, residential camp, and kids lose weight. And then when they go home, we observe majority of them regain their weight. Of course, when the context kicks in, all the old habits are triggered, and well, the effect is lost at a big cost for the payer. So what can we do? We tend to send them messages, and the messages inform what they can do every day in their lives to maintain their weight loss. Eat 5 portions of fruit and veg per day, eat a small plate, because you tend to eat less if you reduce the plate sizes, walk 10,000 steps a day, and so on and so forth. And these messages have no effect, we observed. So we used a nudge message, which simply was a question. After you send the information to the person, you add a question. Do you promise to do so? Click yes. That's it. And when the person clicks yes, and most of them do, they feel committed, psychologically committed to enact this behavior, even though there's no consequence if you don't do so. This psychological commitment is from the framework Mindspace. We respond to our public promises. We respond to our public promises. We feel psychologically committed if we promise publicly to do something. And of course, in the intervention that we designed, sending this commitment question, do you promise to do so, resulted in the kids or the teenagers in the intervention condition who got the commitment question not regaining weight. And the ones who just got information about things that they should do during their days, they didn't regain the weight. As you can see here, we can communicate the nudges or send these techniques to influence the respondent to a digital device. And we have no control over what situation they act on and where they find themselves when they receive the message and the nudge in this case.
Lovely. I'm going to read the next one. As Maya just replied here on the chat. Would you like to ask a question, Maya? Because yours would be next, or would you like me to read it?
I'm happy for you to read it. Thank you.
Okay. So the question that we got earlier was, how do you account/design for cultural differences? Is the assumption that all humans react in the same way to nudges?
They tend to, because these nudges evolve in everybody's brain. Actually, we find the effect of this automatic influence on behavior in cultures and societies so indigenous that they've never been exposed to other culture. They still respond in these ways. There's so much research in the last 50 years on this automatic influence on behavior. but the culture could be a moderator of the effect, how strong the impact is. For example, take N for norms in mind space. We automatically respond and imitate others' behaviors. This is a social norm. Well, we all tend to subconsciously and automatically imitate what our peer group is doing. But in some cultures, like more collectivistic cultures, such as Asian societies, they're more likely to do so. And in more individualistic cultures, like our society, for example, they're less likely to do so. But still, there is an overall effect in both cultures, but the magnitude of the effect is different depending on the culture and the society. And of course, you can investigate individual difference or cultural difference across all other automatic behavioral influences. I mean, I can bang on for longer about these cultural differences, but you get what I'm saying. It's an important question. Also, the same about individual differences, like personality traits. They also moderate or mediate the effect of different techniques. And this is why you need to run randomized trials to see which nudge or technique works best, really, depending on these other factors that are taken into account in the trial.
Lovely.
Any question? I see a lot.
I have some written down for a day. We will copy them throughout the presentation. The next one's from Angela, who asks, "How do you?" Oh, I wrote it wrong. I have to go up and catch it again. I'll ask Hilly's question then, and I'll get the other one. And Hilly said, "How does behavior change? How does behavior change work? Take account of the why of behavior beyond a behavior account of motivation/intention. Example, COVID increased hand hygiene because we were more aware it could save lives. Are there instances of behavior change work with relational factors, organizational, societal attitudes that is multidisciplinary?"
Well, of course, we do. And if you look at the frameworks that I present, they do take into account these factors. So, for example, during COVID, we had this national campaign, Protect Others or Protect Each Other, which was based on this reciprocity principle, actually from Mindspace. We tend to reciprocate acts of kindness automatically. We are motivated to reciprocate acts of kindness. And if we feel that people are doing something nice to us, such as protecting us by wearing a mask or staying at home, if that's known, I'm more likely to reciprocate by doing the same thing. And this is automatic effect. Actually, it's in the Mindspace framework. Just one example. And of course, you need to take into account beliefs and attitudes, the reflective, rational reasoning, which is still there. We're not always automatic, walking around triggered by the environment. Even though the majority of human behavior just comes about, it's not the reflective thought about, we still reflection, we still rationally process information. Don't throw the baby with the bathwater. Still, we need to persuade, educate, prompt people to reason and reflect on their actions. And that's an important part of every intervention, which is why in reality, we have complex multifactorial interventions, persuasion, education, training, in addition to all other automatic influences to maximize the impact of our intervention, taking into account structural barriers as well. Lack of resources, for example, lack of time, lack of space. I cannot nudge somebody if there's no space to enact the behavior, so we need to provide space. If they haven't got any time, well, I can nudge them as much as I want. They might be super motivated because of my subtle subconscious techniques, but I haven't got the time to enact it, so we need to provide them a bit of time or help them structure their time, prioritize their tasks in order to enact the behavior. We find that a lot in care, in primary care, where GPs are quite overwhelmed and they have to provide quick advice, for example, for patients when they see somebody is at risk. You know, the campaign Every Encounter Counts. And it's only a couple of minutes, quick advice about lifestyle, but still many of them are not doing it because they lack the time or they forget about it. So that's why you need to prompt them on the screen of the computer, prompt them to, when they're entering data, and the patient is at risk, obviously overweight, high blood pressure, etc. And then prompt them about lifestyle change. But if the clinician lacks time, what can we do about it? So we need to work with the whole system. And that's why I started my presentation with systems thinking, understanding the system, the structural barriers, as well as the psychological factors, as well as the other influence on behavior. I mean, we influence each other as well. We need to understand that one person influences another person. If you change that person's behavior, that might have a knock-on effect on somebody else's behavior, which has a reverse causal link on this first person's behavior. All these facts need to be taken into account. That's why when we do the nudgeathons, so hackathons to design behavior change interventions, we start drawing the systems, the actors, the actions of these actors in this specific system, and the influence on their behavior, how they interact with each other causally. And then from there, we zoom in on a specific action or actor, and then try to understand the barriers or the enablers of their behavior. And then from there, we go to design interventions using the checklist or the comprehensive unsystematic frameworks for behavior change intervention design, such as Mindspace or the behavior change wheel.
Lovely. Just as a general info, in general, in most Q calls, this is the moment that we stop the recording, but there's at least 3 different people who asked us to record the rest of the Q&A because they're very interested in what comes after it. So this time around, I think I'm just gonna keep the film rolling, and we have 2 more questions here. And folks, you can ask more questions after that. There's no limitation to those 2 questions. We have a couple of extra minutes. The other question I have here is from Angela, who said, considering personality traits / characteristics, are some people more influenced by nudges than others?
I have not seen evidence about specific personality traits being more influenced by nudges in general, right? But we could imagine there are some difference with respect to specific nudges. You know, the big 5 conscientiousness, for example, people who are more conscientious may be more influenced by nudging them to follow what their colleagues are doing, or something to do with their professional role and identity, or their ego, as we call it in the Mindspace language. We strive to have positive self-image and to have also consistent self-image. So if you nudge the person to do something by reminding them about the positive self-image professionally as well, not just physically appearance, if they're conscientious, more conscientious than others, they may be more likely to respond to this nudge that prompts the desire to adhere to positive and consistent self-image or role and professional identity, for example, and so on. It's a good, interesting question, actually, to run maybe trial. I'm just welcoming the audience to get in touch and maybe share their ideas, and we can work together in future. And the nudgeathon that I presented essentially is with the community of quality improvers. We invited your colleagues to participate in the hackathon event to design the intervention that I presented at the end. So some great ideas come from this hackathon.
Lovely. I have one last question here, and then I'll open to the floor. And it's from Laura, who said, I'm struggling a bit with the ethos / philosophy of nudge. Nudge seems to be about altering the environment to change people's behavior, often without them realizing it, which seems the opposite approach to most of our improvement work in the NHS, which is about sustainability. We're trying to build capability and capacity for change by helping others to act intentionally. Any reflection on this?
As I said, automatic influences go along with reflective influences. We work with the whole person, with the whole system, in fact, which contains persons who are reflective and automatic at the same time. And in this way, we maximize the impact of our interventions. Because sometimes people are quite grateful, most of the time, and accepting these automatic influences. So we need to gain the permission of the recipient of the intervention to run this intervention. Of course, this is the first task, that more to designing interventions. And after we come up with these ideas, we rate or rank or approve our ideas by going through the Appease Framework, another sexy acronym. We have all this in place in our toolkit. Appease stands for acceptability, practicality, affordability, and so on. So we need to gain the acceptability of this intervention from the recipient of the intervention by asking them, what do you think? If we do that in your work setting, would that be acceptable? Would that help you? Many clinicians say, yes, I forget to wash my hands, so if the smell reminds me, great. I don't even think about it. Or the 2 eyes above the dispensers, yeah, sure. I'm not intimidated. It helps me think about it and make me realize that, yeah, it's a good thing to do. And you saw the intervention that was designed at the Nudgeton event, the one I shared at the end. They all had this kind of a subtle techniques embedded in them, and you can look at the slides and actually read the article. It's going to be provided to you, which contains all the reasons and reflections about these interventions. And they are quite happy with this intervention. In fact, they find them ingenious and also really likely to be impactful. We haven't got a chance to test them, so if you really want to test some ideas, welcome, and be in touch. And finally, about the ethics of nudging, there are 2 key arguments which have been going on for about 10 years now. A, you're not taking freedom away when you're nudging people. You're not coercing them. And B, if you don't nudge them in this automatic way, you're still leaving them where they are at the moment, which is not good in many situations, and maybe not ethical. So you need to kind of make this trade-off. Shall we leave people the way they are? Or shall we nudge them automatically, leaving them free to choose otherwise, if they want not to comply with the nudge or the motivation that nudge creates? Because obviously the nudge triggers a motivation, and you might behave otherwise still. I mean, there are many motivations that I suppress and don't act on, as you can imagine. That's why it's called libertarian paternalism. You're libertarian in the approach, but paternalistic by influencing behaviors in automatic and often subconscious ways. But we always gain, or try to gain, the acceptability of the populations, individuals that we are about to nudge.